Welcome back to Pain Management and Comfort. We will be finishing up this information with this lecture. When we are talking about pain management, really the most effective way or things we need to consider when we are giving pain medication is the route of administration. So this talks about it being transmucosal or transdermal, the timing of the analgesia. So do we have enough analgesia on board that our patient is going to be comfortable until that next dose is due, or are they having breakthrough pain? If they're having breakthrough pain, then we need to administer maybe a fast-acting instant released medication, and then go ahead and talk to your physicians and think about increasing the routine doses. Also, with timing of analgesia, we need to consider that we need to give this medication prior to our patients ambulating or doing any kind of movement or whatever exacerbates the pain that they're having. We want to make sure that we're timing our analgesia correctly. Monitoring for side effects. We know that one of the major side effects is respiratory depression, but we also need to monitor for constipation, nausea, vomiting, sedation, and those kinds of things. And then it's always important to evaluate and reassess how effective that pain medication or the pain regime is working. So after, you need to evaluate your patient prior to giving pain medication, allowing the pain medication to work, and then you need to monitor them after the medication is given. So at the bare minimum, a focused pain assessment should be with each new onset of pain, before and after administration of medication or doing any type of intervention. And then it's also going to depend on the stability of the patient. So if it's somebody you're giving IV push morphine to every 10 minutes, then obviously you'll need to be assessing them every 10 minutes. If it's somebody that has a 12-hour long-acting MS cotton, then, giving them some time and seeing how they're doing throughout the day is going to be, adequate for them. This is a picture with a adolescent girl that has EMLA cream on, and EMLA cream is sitting right here on our antecubital area. You will oftentimes see EMLA cream used topically and then covered with an opsite, and what that does is helps numb the tissues underneath without doing anything invasive. And then when we're ready to do the IV stick or the lab draws, those types of things, this is going to be really good for that. You're going to notice that I'm going to kind of move quickly through the following slides because it is stuff that I've already discussed. But when we start talking about medications in class, I would be aware of Tylenol and aspirin. Those are going to be the most common non-opioids, along with NSAIDs, Motrin, ibuprofen, naproxen, and then Celebrex is a COX-2 inhibitor, and we see that being utilized for long-term use with some of our patients. So those are going to be medications you need to be aware of. These slides you will have in your packet. So with aspirin, just remember what the effectiveness are, what its effects are, and then things that you need to watch for. And this talks about salicylate poisoning. So if a child would get a hold of a bottle of aspirin, things that you need to be aware of with those. And we will discuss things further in class, as I've said. With NSAIDs, no pain, no flame. NSAIDs are really good for anti-inflammatory effects. However, we do want to watch for GI distress, so we do want to make sure that we're administering these with food. The opioids we discussed earlier, the pure agonists are going to be those with morphine. So your Oxycontin, oxycodone, methadone, codeine, those are going to be ones that are pure agonists, and I did talk about them blocking that release of neurotransmitters. They can be administered by every route, so PO, IV, sub-Q, inhaled, buccal, or sublingual. What am I missing? IM, IV, so pretty much every route that you can think of. There usually is a PRN range of orders that you can follow. It's typically like 1 to 2 milligrams every, it could be every 10 minutes or it could be every hour. And then there's also the utilization of a PCA, and we'll talk more about those in just a bit. With morphine, the opium poppy is one of nature's ways of controlling pain. So this is how we get our morphine derivatives. It is the most common drug for pain control. The side effects, however, rash, respiratory depression, bradycardia, constipation, we do need to be watching for those, especially for respiratory depression if we are giving our patient IV push or a PCA. Narcan, as I said earlier, is going to be your antagonist to reverse the effects of the morphine, so be cognizant of that as well. Other adjunct therapies, I did briefly talk about the SSRIs, or the selective serotonin reuptake inhibitors. We will be seeing those along with muscle relaxants, antispasmodics. Those are going to be really good for your neuropathic pain, chronic pain, pain that is not going to be controlled well with the opioids. Anti-epileptic drugs, you see Topamax utilized in patients that have recurrent headaches or migraine headaches because it does work very well on the brain. And then we talked a little bit about local anesthetics. So just kind of be cognizant of this adjunct therapy, and we'll talk more in depth when we get to class. Your PCA, your patient-controlled analgesic, this is typically what they look like. When you're setting up a PCA, you will have to input all the information. So you will be responsible for programming this little computer. When you program it, typically it's 1 milligram every 10 minutes, not to exceed 6 milligrams in an hour if you're using IV morphine. So you will set that up as 6 milligrams every hour with a maximum 6 milligram dosage in 1 hour. You also on this machine will find the number of attempts to injections. So when your patient, every time they push that button that they hold, it will register in the machine. And so if they are pushing and pushing and pushing and pushing, it will register how many attempts they've made, but it will only give them 1 milligram every 10 minutes. You can oftentimes set these up with a basal rate, so maybe they're going to get 1 or 2 milligram basal rate, and that just will slowly infuse over the course of an hour. It all is going to depend on your physician's order, so just make sure that you are looking at those orders closely and following them to the T. If you have any concerns when you're setting up PCAs, it's not a bad idea to double check those with another nurse. The World Health Organization ladder in regards to analgesic just gives physicians and prescribers a recommended guideline for prescribing pain medication, and it does go off of the 0 to 10 rating scale. And so it talks about the lower levels 1 to 3, and we want to use non-opioids, so that would be using like Tylenol, aspirin, the NSAIDs, those types of things. Level 2 is that the pain is getting a little bit more, so maybe we need to use some weak form of opioid, and then also we can either add that to the non-opioid or try with another adjunct drug. So maybe some Lortab, Vicodin, Lortab has the acetaminophen and Vicodin in it, so that might be something to consider. But the big thing with those is we do need to educate our patients not to take any additional acetaminophen, because then they'll get into those toxic levels. When our patient's pain is at a 7 to 10, that would categorize them as a level 3, and that's when we're going to need to start using strong medications, so the full opioids, morphine, MS-Contin, oxycodone, Duramorph, fentanyl, Duragesic, those types of things. So the higher their pain level, the more medication we need to administer them. When we talk about spinal analgesia, that would include epidural as well as intrathecal. The major differences between the epidural analgesic, it's usually an opioid analgesic alone or with combination of local anesthetics. And really oftentimes what I see is nurse anesthetists, just because we just have nurse anesthetists in this area. I do see them injecting bupivacaine along with that, and that helps prolong the effectiveness of the epidural. Typically, we use epidurals with patients that have respiratory diseases or some comorbidity, and general anesthetic just wouldn't be, a very good idea for them. So the most often utilized drug is fentanyl, also known as Sublimase. And with the epidural, you can either give it as a one-time dose, or you can boost them, or they can use a patient-controlled epidural analgesia where they push a button just like a PCA and administer their medications. When we are utilizing spinal analgesia, we still need to monitor for side effects or complications. So complications that occur are typically related to the catheter placement because it does go into such a small space and it is very near the spinal column, but they are going to be at risk for infection because we are breaking the skin. So good aseptic technique during catheter placement is important. We also know that there is pruritus, very, very common, nausea and vomiting as well. Narcan is going to be the antidote. For the itching or the pruritus, we will see Benadryl or maybe really low dose Narcan used to help decrease the itching that comes from it. Urinary retention is another complication that we need to be watching for. When we are monitoring patients' respirations and sedation level, we do need to report any concerns to our care provider, because if that epidural is starting to go up higher than the space that it was inserted, that can alter respiratory function and have really bad outcomes and respiratory depression to our patients. So we do need to be very cognizant of that. Typically, long-term effects aren't very common. A spinal headache is another thing that may occur, and the way they treat that is that they give the patient what's called a blood patch. So they will draw about, I think it's 10 to 20 cc's out of the antecubital of the patient, and then they will inject that into the epidural space where they had placed the epidural catheter, and then that will form a clot so that cerebral spinal fluid stops leaking. Oftentimes, once they do this blood patch, the patient has just almost immediate relief. Prior to them doing a blood patch, though, other things that we try are lots of caffeine. We keep the head of the bed flat because elevating it really causes them a lot of distress. And then just, a quiet environment, cool cloths, anything like that. The intrathecal is just a partial pain blocking agent, and it is placed between the arachnoid matter and the pia mater of the spinal cord, and that's where the cerebral spinal fluid is located. We might see intrathecals used for intractable chronic long-term pain that can't be managed using any other standard therapies. So you may see intrathecals being utilized as well. This is just a picture of the catheter going into our patient's back, so you can see it right there. And then you can see there's a little pale fluid in here, and that would be your cerebral spinal fluid. Non-pharmacologic measurements that we have discussed earlier: distraction, relaxation, guided imagery. With our infants, containment and swaddling, non-nutritive sucking, so using pacifiers, using sucrose water, those types of things, and then also kangaroo care. So this picture is just a display of a couple of different things. You can see this nurse is working on the baby's heel, probably getting ready to do a heel stick, and this nurse has the baby swaddled and then also offering the pacifier. So we want to make sure that we are keeping those babies as comfortable as possible, because infants also are a very untreated group of patients for pain management. This would be kangaroo care, and it's recommended for newborns, especially low birth weight, preterm, that can be held. That skin to skin, directly on mom's skin, is very, very good. It helps parents learn how to be a parent. Helps achieve role attainment and developmental skills for the young adult. So it's a really good idea just to have those bonding experiences with the baby. We did talk about this mind-body technique, the distraction imagery. I didn't talk about hypnosis, but that is also out there to use in adjunction with medications. Acupuncture, glucosamine, complementary pain medication, manipulative treatment, so seeking the chiropractor, acupressure, massage, any of those kinds of things are going to be very good to help increase the effectiveness of our pain medications. Physical interventions, the heat and cold applications, so ice, heat, therapy, massage. The vibration, that would be kind of in relation to this TENS unit, and what this does is it sends electrical currents into those muscles to try to help decrease the pain that the patient is feeling. So this is called a TENS unit, and you will see this oftentimes utilized with physical therapy. Looks like I'm going to run out of time, so I will finish up with one more presentation.